This is Emergency Care and Transportation of the Sick and Injured, Chapter 19, Endocrine and Hematologic Emergencies. After you complete this chapter and its related coursework, you will understand the significance and characteristics of diabetes, sickle cell disease, clotting disorders, and the complications associated with each. You will also be able to demonstrate knowledge of the characteristics of type 1 and type 2 diabetes and be able to list the appropriate steps for assessment and pre-hospital treatment of diabetic emergencies. You will also be able to discuss hematologic emergencies and describe sickle cell disease, hemophilia, thrombophilia, and deep vein thrombosis. The human endocrine system, directly or indirectly, influences nearly every cell, organ, bodily function, and endocrine disorders are often seen with a multiple of signs and symptoms. Hematologic emergencies are difficult to assess and treat in a pre-hospital setting. Your actions may save a patient's life. Let's discuss the anatomy and physiology. The endocrine system is a communication system that controls functions inside the body. Endocrine glands secrete messenger hormones. Hormones are chemical substances produced by a gland. They travel through the bloodstream to end organs, tissues, or cells that they affect. When it arrives, the message is received and an action takes place. Endocrine disorders are caused by an internal communication problem. If a gland is not functioning normally, it may produce more hormone, which is hyposecretion, than needed, and not enough hormone, which is hyposecretion. A gland may be functioning correctly, but the receiving organ may not be responding. Let's talk about glucose metabolism. The brain needs two things to survive: glucose and oxygen. Insulin is necessary for glucose to enter cells. Without enough insulin, the cells do not get fed. The pancreas produces and stores two hormones, glucagon and insulin. The islets of Langerhans are found in a small portion of the pancreas. Within the islets are alpha and beta cells. Alpha cells produce glucagon, and beta cells produce insulin. The pancreas stores and secretes insulin and glucagon in response to the level of glucose in the blood. Now, the pathophysiology is what we're going to discuss next. Diabetes is a disorder of glucose metabolism such that the body has an impaired ability to get glucose into the cells to be used for energy. It affects about 9.3% of the population. Without treatment, blood glucose levels become too high. In severe cases, it may cause life-threatening illness or coma and death. If not managed well, it can have severe complications such as blindness, cardiovascular disease, and kidney failure. There are three types of diabetes: diabetes mellitus type 1, diabetes mellitus type 2, and pregnancy-induced gestational diabetes. The treatments for diabetes are as follows. There are medications and injectable hormones that lower blood glucose level. If administered correctly or incorrectly, it can create a medical emergency for the patient with diabetes. Low blood glucose level, hypoglycemia, if unrecognized and untreated, can be life-threatening. You must also recognize the signs and symptoms of high glucose level, which is hyperglycemia, and it can result in coma or death. If treatment exceeds a patient's need, it can cause a life-threatening state of hypoglycemia. Low blood glucose level, hypoglycemia, and hyperglycemia and hypoglycemia can both occur with diabetes mellitus type 1 and type 2. You will encounter many patients displaying the signs and symptoms of high and low blood glucose levels. Hyperglycemia and hypoglycemia can be quite similar in their presentation. You have patients with altered mental status, and it can often mimic alcohol intoxication. Intoxicated patients often have abnormal glucose levels. Hypoglycemia can develop if a person takes his or her medication but fails to eat enough food. If a person takes too much medication, resulting in low blood glucose levels despite normal dietary intake, that can occur as well. All hypoglycemic patients require prompt treatment. Oral glucose paste if the patient is alert and able to protect their airway. Injection of glucose, which is dextrose, or glucagon, can be provided by an ALS provider. Let's talk about diabetes mellitus type 1. It's an autoimmune disorder in which the immune system produces antibodies against the pancreatic beta cells. This missing the pancreatic hormone insulin is the result. Without insulin, glucose cannot enter the cell and the cell cannot produce energy. The onset with type 1 diabetes mellitus usually happens from early childhood through the 4th decade of life. The immune system destroys the ability of the pancreas to produce insulin. The patient must obtain insulin from an external source. Patients with type 1 diabetes cannot survive without insulin. Patients who inject insulin often need to check blood glucose levels up to 6 times or more a day. Many people with type 1 diabetes have an implanted insulin pump. It continuously measures glucose levels and provides insulin and correction doses of insulin based on carbohydrate intake at meal times. It limits the number of times patients have to go to check their fingerstick glucose levels. However, this can malfunction and diabetes emergencies can develop. Always inquire about the presence of an insulin pump and ask if it is working properly. Type 1 diabetes is the most common metabolic disease of childhood. A patient with new onset type 1 diabetes will have symptoms related to eating and drinking, polyuria, polydipsia, polyphagia, and weight loss and fatigue. When a patient's blood glucose level is above normal, the kidney's filtration system becomes overwhelmed and glucose spills into the urine. Polyuria is frequent urination. Polydipsia is an increase in fluid consumption. Polyphagia is severe hunger and increased food intake. When glucose is unavailable to cells, the body turns to burning fat. When the body burns fat rather than glucose, it produces acid waste or ketones. As ketone levels go up in the blood, they spill into the urine. The kidneys become saturated with glucose and ketones and cannot maintain an acid-base balance in the body. The patient breathes faster and deeper as the body attempts to reduce the acid level by releasing more carbon dioxide through the lungs. This is known as Kussmaul respirations. If fat metabolism and ketone production continue, a life-threatening illness called diabetic ketoacidosis, DKA, can develop. DKA may present as generalized illness along with abdominal pain, body aches, nausea, vomiting, and an altered mental status or unconsciousness if it is severe. If not rapidly recognized and treated, DKA can result in death. When a patient with DKA has altered mental status, ask a family or friends about the patient's history and presentation. Obtain a glucose level with a finger stick using a lancet and glucometer. Generally, you will find readings higher than 400 milligrams per deciliter. Now let's talk about diabetes mellitus type 2. This is caused by resistance to the effects of insulin at the cellular level. There is an association between obesity and increased resistance to the effect of insulin. The pancreas produces more insulin to make up for the increased level of blood glucose and dysfunction of cellular insulin receptors. The response then becomes inefficient. The blood glucose levels continue to rise and do not respond when the pancreas secretes insulin, which is a process called insulin resistance. Insulin resistance can sometimes be improved by exercise and dietary modification. Oral medications are frequently used to treat type 2 diabetes. Some increase secretion of insulin and pose a high risk of hypoglycemic reaction, however. Some stimulate receptors for insulin, and other medications decrease the effect of glucagon and decrease the release of glucose stored in the liver. Injectable medications and insulin are also used for type 2 diabetes. Type 2 diabetes is often diagnosed at a yearly medical examination from complaints related to high blood glucose levels, including recurrent infection, change in vision, numbness in the feet. Symptomatic hyperglycemia occurs when the blood glucose levels are very high, the patient is in a state of altered mental status, resulting from severe combined problems. In type 1 diabetes, it leads to ketoacidosis with dehydration from excessive urination. In type 2 diabetes, it leads to non-ketonic hypersmolar state of dehydration due to the discharge of fluids from all of the body systems and eventually out through the kidneys, leading to fluid imbalance. If an individual has hyperglycemia for a protracted length of time, consequences of diabetes may present wounds that do not heal, numbness in the hands and feet, blindness, renal failure, and gastric motility problems. When blood glucose levels are not controlled in diabetes mellitus type 2, a condition known as hypersmolar hyperglycemic noncatonic syndrome, HHNS, can develop. Key signs and symptoms of HHNS include hyperglycemia, altered mental status, drowsiness, and lethargy. It can also result in severe hydration, thirst, and dark urine. Included are visual or sensory deficits and partial paralysis or muscle weakness, and can lead to seizures. Higher glucose levels in the blood cause the excretion of glucose in the urine. Patients respond by increasing their fluid intake, which causes polyuria. In HHNS, the patient cannot drink enough fluid to keep up with the exceedingly high glucose levels in the blood. The urine becomes dark and concentrated, and the patient may become unconscious or have seizure activity due to severe dehydration. Let's talk about symptomatic hypoglycemia. This is an acute emergency in which a patient's blood glucose level drops and must be corrected swiftly. It can occur in patients who inject insulin or use oral medications that stimulate the pancreas to produce more insulin. When insulin levels remain high, glucose is rapidly taken out of the blood. If glucose levels fall, there may be an insufficient amount to supply the brain. The mental state of the patient declines, and he or she may become aggressive or display unusual behavior. There may also be unconsciousness and permanent brain damage that can quickly follow. Now we're still talking about symptomatic hypoglycemia. Common reasons for a low blood glucose level to develop are correct dose of insulin with a change in routine. In other words, the patient exercised more, consumed a meal later than usual, or skipped the meal. They also could have taken more insulin than necessary, and a correct dose of insulin without the patient eating a sufficient amount. correct dose of insulin, and the patient develop an acute illness. Hypoglycemia develops much more quickly than hyperglycemia. In some instances, it can occur in a matter of minutes. Signs and symptoms of hypoglycemia are normal to shallow respirations, pale, moist, and clammy skin, diaphoresis, which is really heavy sweating, dizziness and headache, rapid pulse, and they can have normal to low blood pressure. Continuing with symptomatic hypoglycemia, you can also have an altered mental state, which is aggressive, confused, or lethargic, or unusual behavior. You can also have anxious or combative behavior, seizure, fainting, or coma, and also weakness on one side of the body that may mimic stroke. There can also be rapid changes in mental status, so be prepared for that. Hypoglycemia is quickly reversed by giving the patient glucose. Without the glucose, however, the patient could sustain permanent brain damage. Minutes absolutely count. This is a chart that shows how hypoglycemia is quickly reversed by giving the patient glucose. Now let's talk about scene size up. When you form your primary assessment, form a general impression. In other words, how does the patient look? Are they anxious, restless, or listless? Do they have apathy? In other words, are they apathetic or irritable? Are they interacting appropriately with the environment? And identify life threats and provide life-saving interventions, particularly airway management. Determine the level of consciousness using the AVPU scale. If unresponsive and you suspect the patient have diabetes, call for ALS. The patient may have undiagnosed diabetes. If the patient has an altered mental status, assess blood glucose level if you have proper equipment and training. Perform cervical spine immobilization when necessary and provide rapid transport. Remember, always carry out a thorough, careful primary assessment, paying attention to the ABCs. Assess the patient's airway and breathing. If the patient is showing signs of inadequate breathing, a pulse oximetry level less than or equal to 94% or an altered mental status should receive high-flow oxygen, which is 12 to 15 liters per minute, via non-rebreathing mask. Hyperglycemic patients may have rapid, deep Kussmaul respirations and sweet, fruity breath. Hypoglycemic patients will have normal to shallow rapid respirations. If the patient is not breathing or is having difficulty breathing, open the airway, insert the airway adjunct, administer oxygen, assist ventilations, and continue to monitor ventilations throughout the patient's care. Assess the patient's circulatory status. Warm, dry skin usually indicates hyperglycemia. Moist, pale skin usually indicates hypoglycemia. Also, a rapid, weak pulse is symptomatic of hypoglycemia. Make a transport decision. Patients with altered mental status and impaired ability to swallow should be transported promptly. Patients capable of swallowing and conscious enough to maintain their own airway may be further evaluated on scene and interventions can be performed. History taking is important. If the patient has taken insulin but not eaten, hypoglycemia is more likely. Observe physical signs and symptoms to determine whether the patient is hyperglycemic or hypoglycemic. Obtain a sample history from a responsive patient, either the responsive patient or a family member or bystander. For a known patient with diabetes, ask, do you take insulin or pills that lower your blood sugar? Do you wear an insulin pump? Is it working properly? Have you eaten normally today? Have you had any illness, unusual amount of stress or activity? Look for an emergency medical identification tag, such as a wallet card, necklace, or bracelet. In your secondary assessment, do a physical examination and assess unresponsive patients from head to toe with a secondary assessment of the entire body. Look for clues about the patient's condition. Be alert for secondary injury or illness, such as trauma due to an altered level of consciousness. When you suspect a diabetes-related problem, focus on mental status, ability to swallow, and ability to protect the airway. Obtain a Glasgow Coma scale or a GCS score. Make sure to check vital signs, including blood glucose level. Use a glucometer if available and protocols allow. Overall, you should look at the following. Hypoglycemia. When you see hypoglycemia, respirations are normal to rapid, pulse is weak and rapid, and skin is typically pale and clammy with a low blood pressure. Hyperglycemia, you will have respirations that may be deep and rapid, the pulse may be rapid and weak and thready, and the skin may be warm and dry with a normal blood pressure. With portable glucometers, study the operator's manual for proper use in the field. Know the upper and lower ranges at which your glucometer functions. Normal, non-fasting adult and child blood glucose levels range from 80 to 120 milligrams per deciliter. Neonates should be above 70 milligrams per deciliter. For reassessment, reassess the patient with diabetes frequently to assess any changes. Do they have improved mental status? Are ABCs intact? How is the patient reacting to interventions performed? How must you adjust or change interventions? Base administration of glucose on serial glucometer readings or a deteriorating level of consciousness. Provide the indicated interventions. For hypoglycemic patients that are conscious, who can swallow without the risk of aspiration or inhalation of a substance, encourage the patient to take glucose tablets if available, or drink juice containing sugar. Administer gel preparation or sugar drink if local protocol permits. Provide rapid transport to the hospital. For unconscious hypoglycemic patients or patients with risk of aspiration, intravenous or IV glucose or intramuscular IM or intranasal IN glucagon is needed, which most EMTs are not permitted to give. AEMTs and paramedics can start an IV line and administer IV glucose. If in doubt, whether that patient has symptomatic hyperglycemia or hypoglycemia, most protocols will err on the side of giving glucose. When in doubt, consult medical control. Determining blood glucose level in a patient with diagnosed diabetes can be difficult when signs and symptoms are confusing and you have no way to test for a blood glucose value. In these situations, perform a thorough assessment. Contact the hospital to help sort signs and symptoms. Coordinate communication and documentation. Inform the receiving hospital about the patient's history, the present situation, your assessment findings, and your interventions and their results. Patients who refuse transport because of their symptoms improve after taking oral glucose may require even more thorough documentation. So let's talk about emergency medical care for diabetic emergencies. Giving oral glucose. There are 3 types of oral glucose preparations available commercially. There's a rapidly dissolving gel, large chewable tablets, and a liquid formulation. The only contraindications are the inability to swallow and unconsciousness. Aspirations can occur. Wear gloves before putting anything in the patient's mouth. Follow local protocols for glucose administration and see Skill Drill 19-1 in your text. Reassess the patient frequently. You may see rapid response to your treatment, and you may also see rapid deterioration. Provide transport to the next level of care. The presence of hypoglycemia. You may have seizures, and that should be considered very serious, even in patients with a history of chronic seizures. The possible causes could be infection, poisoning, hypoglycemia, trauma, decreased level of oxygen, idiopathic, which is an unknown cause, fever in children, and an undiagnosed epilepsy in children. Though brief seizures are not harmful, they may indicate a potentially life-threatening underlying condition. The management of this is to ensure that the airway is clear, place the patient on her side if there is no possibility of cervical spine trauma. Do not place anything in the patient's mouth, such as a bite stick or an oral airway. Have suction equipment ready in case the patient vomits. If the patient is cyanotic or appears to have breathing inadequately, provide oxygen or artificial ventilations. Transport promptly. For altered mental status, that may stem from other conditions such as poisoning, head injury, post-ictal state, decreased perfusion to the brain, and it may be caused by complications of diabetes, hypoglycemia, or ketoacidosis. Use the mnemonic AETOU-TIPS. Always suspect and check for low blood glucose in a patient with altered mental status. For management, you want to ensure that the airway is clear. Be prepared to provide artificial ventilations. Be prepared to suction if the patient vomits. Provide prompt transport, and misdiagnosis of neurologic dysfunction is occasionally possible with patients with diabetic emergencies that are thought to be intoxicated. A diabetic patient confined by police is at risk. An emergency medical identification bracelet, necklace, or card may help to save the patient's life in such situations. A blood glucose test performed at the scene, if protocols allow, or in the ED, will identify the real problem. Be alert to the potential for diabetes and alcoholism to coexist in a patient. Let's talk about relation to airway management. They may not have a gag reflex and vomit, or the tongue may obstruct the airway. Carefully monitor the airway. Place the patient in a lateral recumbent position. Make sure that suction is readily available. For hematologic emergencies, hematology is the study of blood-related diseases. 3 disorders that can create a pre-hospital emergency are sickle cell disease, hemophilia A, and thrombophilia. Let's discuss the anatomy and physiology of these. Blood is made up of 4 components: erythrocytes, leukocytes, platelets, and plasma. Each of the components of the blood serves a purpose in maintaining the body's homeostatic balance. Blood transport oxygen and carbon dioxide into and out of tissues. Red blood cells, or erythrocytes, contain hemoglobin, which carries oxygen to the tissues. Red blood cells make up to 42% to 47% of blood volume. White blood cells, or leukocytes, make up 0.1% to 0.2% of a person's blood cell volume. Collect dead cells and provide for their correct disposal is part of the function of the blood system. It responds to infections. Platelets make up to 4 to 7% of a person's blood cell volume. Blood is essential for clot formation and respond to skin or blood vessel damage. They also assist in forming a clot to stop bleeding. Plasma serves as the transportation medium for blood components, proteins, and minerals. The pathophysiology of blood diseases. Sickle cell disease, also called hemoglobin S disease, is an inherited blood disorder that affects RBCs. It's found predominantly in people of African, Caribbean, and South American ancestry. It is present but less common in Mediterranean and Middle Eastern people. All newborns in the United States are tested for sickle cell disease shortly after their birth. People with sickle cell disease have misshapen RBCs or red blood cells that lead to dysfunction in oxygen binding and unintentional clot formation. Clots may result in a blockage known as a vasculative crisis. It can result in hypoxia, substantial pain, and organ damage. Sickled cells have a short lifespan, resulting in more cellular waste products in the bloodstream and contributing to sludging or clumping of the blood. Maintaining hydration is important, as insufficient hydration leads to increased clumping. Complications associated with sickle cell disease include anemia, gallstones, jaundice, splenic dysfunction. Other problems that can occur are vascular occlusion with ischemia, acute chest syndrome, which includes hypoxia, dyspnea, chest discomfort, and fever. It can also cause stroke, joint necrosis, specifically the head of the femur and the humerus, pain crises, an acute and chronic organ dysfunction and failure, and retinal hemorrhage. And there's also an increased risk of infection. Many of these complications are very painful and potentially life-threatening. The patient is also more susceptible to infections. Another blood disease that can cause clotting disorders are hemophilia. Hemophilia is rare. Only about 20,000 Americans have this disorder. Hemophilia A affects mostly males. In people with hemophilia A, they have decreased ability to create a clot after an injury, which can be life-threatening. Patients with hemophilia A typically have intravenous factor VII replacement infusions, which help the blood clot, either close at hand or with them. Common complications of hemophilia A include long-term joint problems that may require joint replacement, and bleeding in the brain, which is intracerebral hemorrhage. Thrombosis due to treatment also can occur. Another clotting disorder that can occur is thrombophilia. This is a disorder in the body's ability to maintain the smooth flow of blood through the venous and arterial systems. The concentration of particular elements in the blood creates clogging or blocking issues. Thrombophilia is a general term for many different conditions that result in the blood clotting more easily than normal. It's an inherited or genetic disorder, and it requires medication or other factors, and it can occur in patients with cancer. Clots can spontaneously develop in the blood of the patient. Now let's talk about deep vein thrombosis, or DVT. This is a common medical problem in sedentary patients and in patients who've had recent injury or surgery. You may encounter several methods to prevent blood clot formation, including blood thinning medications, compression stockings, mechanical devices. Risk factors include recent history of joint replacement and complaints of leg swelling, travelers, truck and long-distance bus drivers, bedridden nursing home patients, or anyone sitting for an extremely long period of time without moving. The treatment for DVT is anticoagulation therapy, in-hospital IV medications that are transitioned to oral medications before discharge, self-administered subcutaneous, injectable, or oral medications. Oral medications are typically administered for at least 3 months after diagnosis of a DVT. Patients prescribed medications to treat DVT are at increased risk of bleeding complications such as gastrointestinal bleeding, and minor trauma is more likely to produce severe internal or external hemorrhage. A clot from the DVT can travel from the patient's lower extremity to the lung, causing a pulmonary embolus. Pulmonary emboli can cause chest pain, difficulty breathing, or sudden cardiac arrest. Patient assessment of hematologic disorders. When you do your scene size up, of course, always ensure scene safety. Most sickle cell patients will have had a crisis before. Wear gloves and eye protection at a minimum. Determine the number of patients involved and be alert for possible trauma. Consider ALS support, such as analgesic administration for vaso-occlusive crisis pain. And then in your primary assessment, is the patient in pain and of African American or Mediterranean descent? If yes, they may have undiagnosed sickle cell disease. Perform cervical spine immobilization if necessary. Form a general impression. Is the patient anxious, restless, or listless? Is the patient apathetic or irritable? Determine the level of consciousness. Assess the patient's airway and breathing. For patients with inadequate breathing or altered mental status, provide high-flow oxygen at 12 to 15 liters per minute via a non-rebreathing mask. Patients experiencing sickle cell crisis may have increased respirations or exhibit signs of pneumonia. For patients with breathing difficulty, open the airway and insert the airway adjunct. Administer oxygen and assist ventilations. Assess the patient's circulatory status. Sickle cell crisis patients will have increased heart rate to force the sickled cells through smaller blood vessels. For suspected hemophilia patients, be alert for signs of acute blood loss. You want to look for pallor, weak pulse, and hypotension, and note bleeding of unknown origin, nosebleeds, bloody sputum, blood in the urine or stool, and be alert for signs of hypoxia, which is due to blood loss. Make a transport decision. Transport to an ED should always be recommended to any patient who's experiencing a sickle cell crisis or hemophilia. History taking. Investigate the chief complaint. Obtain a history of the present illness from responsive patients, family, or bystanders. Be alert for physical signs indicating sickle cell crisis, like swelling of the fingers and toes, priapism, jaundice. You should also ask the following questions. Is the pain isolated to a single location or felt throughout the body? Is the patient having visual disturbance? Is the patient experiencing nausea, vomiting, or abdominal cramping? Is the patient experiencing chest pain or shortness of breath? Obtain a sample history from a responsive patient or a family member. Have you had a crisis before? When was the last time you had a crisis? How did your last crisis resolve? Have you had any illness, unusual amount of activity, or stress lately? In the secondary assessment, systematically examine the patient. Focus on major joints at which cells congregate. Evaluate and document mental status using the AFPU scale. Obtain a complete set of vital signs, including oxygen saturation level. Normal sickle cell crisis vital signs are normal to rapid respirations, weak rapid pulse, pale clammy skin, low blood pressure. Use the pulse oximeter if available to monitor oxygen saturation. The reading may be inaccurate due to the patient's anemic state. In reassessment, reassess vital signs frequently to determine changes in the patient's condition. Are there changes in mental status? Are the ABCs intact? How is the patient responding to the interventions performed? Adjust or change the interventions as needed. Document each assessment, your findings, the time of the interventions, and any changes in the patient's condition. Administer supplemental oxygen via non-rebreathing mask at 12 to 15 liters per minute to attempt to compensate for decreased cellular oxygenated related to the sickle cells or hemophilia. Hospital care for sickle cell crisis may include analgesics for pain, penicillin to treat infection, IV fluid for hydration, and blood transfusion depending on the severity of the condition. Hospital care for hemophilia may include IV therapy to treat hypotension, transfusion of plasma, and make sure to communicate with hospital staff for continuity of care and document clearly. Emergency medical care for hematologic disorders. Emergency care is mainly supportive and symptomatic. For patients with inadequate breathing or altered mental status, administer high-flow oxygen at 12 to 15 liters per minute via non-rebreathing mask. Place the position in a position of comfort and transport rapidly to the hospital. Type 1 diabetes is a condition in which too much insulin is produced, glucose utilization is impaired, too much glucose enters the cell, or the body does not produce glucose. If you paid attention, this one should be fairly easy. And it is B. Type 1 diabetes is the disease in which the pancreas fails to produce enough insulin or produces none at all. Insulin is a hormone that promotes the uptake of sugar from the bloodstream and into the cells. Without insulin, glucose utilization is impaired because it cannot enter the cell. Let's look at the incorrect answers. Type 1 diabetes is a condition in which A. Too much insulin is produced. That's incorrect because the body only produces the amount of insulin that is needed to enable glucose to enter cells. B. Glucose utilization is impaired. That is the correct answer. C. Too much glucose enters the cell. That's incorrect because an abnormally high blood glucose level is known as hyperglycemia. Or D. The body does not produce glucose. That's incorrect because glucose is derived from the oral intake of carbohydrates. It is stored in different body structures and then metabolized by cells. Question 2. A 45-year-old man with type 1 diabetes is found unresponsive. Which of the following questions is the most important to ask his wife? A. Did he take his insulin today? B. How long has he been a diabetic? C. Has he seen his physician recently? And D. What kind of insulin does he take? Knowing what you know, hopefully at this point, about type 1 diabetes, you should get this answer easily. And it is A. All of these questions are important to ask the spouse of an unconscious diabetic. However, it is critical to ask if the patient took his insulin. This will help you differentiate hypoglycemic crisis from a hyperglycemic crisis. For example, if the patient took his insulin and did not eat, or accidentally took too much insulin, you should suspect hypoglycemic crisis. If the patient did not take his insulin, you should suspect hyperglycemic crisis. Let's look at the incorrect answers. Just to review, a 45-year-old man with type 1 diabetes is found unresponsive. Which of the following questions is the most important to ask his wife? A, did he take his insulin today? That, of course, is the correct answer. B, how long has he been diabetic? That is important, but it's part of the sample history information. C, has he seen his physician recently? This is also important in the sample history information. And D, what kind of insulin does he take? This provides important information about a patient's medication. But of course, the patient is unconscious, and the first question we should ask is about insulin intake, and then obtain sample history after that and get him transported. Number 3. A diabetic patient presents with a blood glucose level of 310 milligrams per deciliter and severe dehydration. The patient's dehydration is the result of A, excretion of glucose and water from the kidneys, B, a deficiency of insulin that causes internal fluid loss, C, an infection that often accompanies hyperglycemia, or D, an inability to produce energy because of insulin depletion. If you paid close attention, you should get this one fairly easily also. And it is A. In severe hyperglycemia, the kidneys excrete excess glucose from the body. This process requires a large amount of water to accomplish. Therefore, water is excreted with the glucose, resulting in dehydration. And these patients often complain of excessive thirst. So that should also give you a little bit of a hint. Let's look at the incorrect answers. Just to review, a diabetic patient presents with a blood glucose level of 310 milligrams per deciliter and severe dehydration. The patient's dehydration is the result of A, excretion of glucose and water from the kidneys, and that is the correct answer. B, a deficiency of insulin that causes internal fluid loss. That's incorrect because a lack of insulin will cause the glucose levels to rise, and it's the glucose that causes the fluid loss. So that's the incorrect answer. C, an infection that often accompanies hyperglycemia. An infection is an invasion of the body by an organism. Glucose is not a foreign element. D, an inability to produce energy because of insulin depletion. A body's inability to metabolize glucose does not cause a fever. Number 4. Which combination of factors would most likely cause a hypoglycemic crisis in a diabetic patient? A, eating a meal and taking insulin. B, skipping a meal and taking insulin. C, eating a meal and not taking insulin. Or D, skipping a meal and not taking insulin. This is actually related to an earlier question we had, so you should be able to get this one right. And it is B. The combination that would most likely cause a hypoglycemic crisis is skipping a meal but taking insulin. The patient will use up all available glucose in the bloodstream and become hypoglycemic. Left untreated, hypoglycemic crisis may cause permanent brain damage or even death. Let's look at the incorrect answers. Which combination of factors would most likely cause a hypoglycemic crisis in a diabetic patient? A, eating a meal and taking insulin. Actually, this process will help maintain the body's glucose level. B, skipping a meal and taking insulin. That, of course, is the correct answer. C, eating a meal and not taking insulin. Eating will actually cause glucose levels to rise, so that's the incorrect answer related to this scenario. Or D, skipping a meal and not taking insulin. Glucose levels should remain the same, but it may be influenced by the patient's metabolic rate or physical activities. This does not cause a hypoglycemic crisis. Question 5. A 19-year-old diabetic male was found unresponsive on the couch by his roommate. After confirming that the patient is unresponsive, you should A, suction his oropharynx, B, manually open his airway, C, administer high flow oxygen, or D, begin assisting his ventilations. Think about this one just for a minute, and let's check the correct answer. It is B. Immediately after determining that a patient is unresponsive, your first action should be to manually open his or her airway with a head tilt, chin lift, and jaw thrust. Use suction as needed to clear secretions from the patient's mouth. After manually opening the airway and ensuring it is clear of obstructions, insert a nasal airway adjunct and then assess the patient's breathing. Let's look at the incorrect answers. A 19-year-old diabetic was found unresponsive on the couch by his roommate. After confirming that the patient is unresponsive, you should A, suction his oropharynx. That's incorrect. After opening the airway, then suction is needed to remove any secretions. B, manually open his airway. That's the correct answer. C, administer high flow oxygen. That's incorrect because it follows after a chain of previous events. After opening the airway, provide oxygen only as needed or indicated clinically. D, begin assisting his ventilations. After opening the airway, assist with ventilations if the patient's breathing is inadequate. Number 6. What breathing pattern would you most likely encounter in a patient with diabetic ketoacidosis, or DKA? Slow and shallow, B, shallow and irregular, C, rapid and deep, or D, slow and irregular? It is C. Kussmaul respirations, which is a rapid and deep breathing pattern seen in patients with DKA, indicates that the body is attempting to eliminate ketones via the respiratory system. A fruity or acetone breath odor is usually present in patients with Kussmaul respirations. Let's look at the incorrect answers. What breathing pattern would you mostly likely encounter with a patient with diabetic ketoacidosis, or DKA? A, slow and shallow. That's incorrect. Agonal respirations are seen with cerebral anoxia and may have an occasional gasp. They're not associated with DKA. B, shallow and irregular. Agonal respirations, again, are seen with cerebral anoxia and may have an occasional gasp. Again, not seen in diabetic ketoacidosis. C, rapid and deep. That's the correct answer because the body's trying to throw off excess carbon dioxide. D, slow and irregular. That's incorrect because slow and irregular respiration results from increased intracranial pressure and can also have periods of apnea. Somebody with DKA is not going to have these types of symptoms. Question 7. A woman called EMS because her 12-year-old son, who had been experiencing excessive urination, thirst, and hunger for the past 36 hours, has an altered mental status and is breathing fast. You should be most suspicious for A, low blood sugar, B, hypoglycemia, C, hypoglycemic crisis, or D, hyperglycemic crisis. Think about this one just for a minute, and I know you'll get the right answer. It is D. The child is experiencing hyperglycemic crisis secondary to severe hyperglycemia. Hyperglycemic crisis is characterized by a slow onset and excessive urination, polyuria, thirst, polydipsia, and hunger, polyphagia. Other signs include rapid deep breathing with a fruity or acetone breath odor, which is Kussmaul respirations, a rapid thready pulse, and an altered mental status. Let's look at the incorrect answers. Just to remind you of the scenario, a woman called EMS because her 12-year-old son, who had been experiencing excessive urination, thirst, and hunger for the past 36 hours, has an altered mental status and is breathing fast. You should be most suspicious for A, low blood sugar, and that's incorrect because low blood sugar does not cause frequent urination. B, hypoglycemia. Hypoglycemia is low blood sugar. That's not what's apparent here. C, hypoglycemic crisis. Hypoglycemic crisis does not produce any of these symptoms that you're seeing in this child. Hyperglycemic crisis is the correct answer. That's exactly what you're seeing in this patient. 8. If the cells do not receive glucose, they will begin to metabolize A, fat, B, acid, C, sugar, or D, ketones. This one should be easy. And it is fat. A. If the body cells do not receive glucose, they will begin to metabolize the next most readily available substance, fat. Fat metabolism results in the production of ketoacids, which are released into the bloodstream, hence the term ketoacidosis. Let's look at the incorrect answers. If the cells do not receive glucose, they will begin to metabolize fat. That's the correct answer. B, acid. Fatty acids are a byproduct or a waste product of the metabolism of fat. So in other words, when the body begins to metabolize fat, it produces fatty acids, which are a waste product of that metabolism of fat. C, sugar. Sugar is glucose, and it's not receiving any glucose, so it begins to consume fat. So obviously that's the incorrect answer. And ketones. Ketones are a byproduct or a waste product of the metabolism of fat. So again, you have another waste product of the body consuming fat. Number 9, in contrast to a hyperglycemic crisis, a hypoglycemic crisis, A, rarely presents with seizures, B, presents over a period of hours to days, C, should not routinely be treated with glucose, or D, usually responds immediately after treatment. Let's take a look at the right answer here. Hypoglycemic crisis usually responds immediately following treatment with glucose. Patients with hyperglycemic crisis generally respond to treatment gradually within 6 to 12 hours following the appropriate treatment. Seizures can occur with both hyperglycemic crisis and hypoglycemic crisis, but are more common in patients with hypoglycemic crisis. Let's look at the incorrect answers. In contrast to a hyperglycemic crisis, a hypoglycemic crisis, A, rarely presents with seizures. Hypoglycemic crisis can produce seizures. B, presents over a period of hours to days. Hypoglycemic crisis has a rapid onset of symptoms. It's possible to occur within minutes, not hours to days. C, should not routinely be treated with glucose. Hypoglycemic crisis is always treated with glucose. If they're hypoglycemic, they're low on blood sugar, they need glucose. D, usually responds immediately after treatment. That's the correct answer. They do generally respond as soon as glucose enters the system. And question 10. Patients with diabetic ketoacidosis experience polydipsia because A, they are dehydrated secondary to excessive urination, B, the cells of the body are starved due to a lack of glucose, C, fatty acids are being metabolized at the cellular level, or D, hyperglycemia usually causes severe internal water loss. This is related to a question we had earlier also, so you should get this one right. And the correct answer is A, severe hyperglycemia, which leads to diabetic ketoacidosis, causes the body to excrete large amounts of glucose and water. As a result, the patient becomes severely dehydrated, which leads to excessive thirst, polydipsia. Let's look at the incorrect answers. Reviewing question 10, patients with diabetic ketoacidosis experience polydipsia because, again, A is correct because they're dehydrated secondary to excessive urination. Now let's look at the incorrect answers. B, patients with diabetic ketoacidosis experience polydipsia because the cells of the body are starved due to a lack of glucose. Well, that is true, but the lack of glucose is not what causes the thirst. It's the excessive fluid loss that causes the thirst. So looking at C, Patients with diabetic ketoacidosis experience polydipsia because fatty acids are being metabolized at the cellular level. That's incorrect because fats are metabolized by the cells instead of glucose, and that's what produces the acids and ketones, thus the term ketoacidosis. So fatty acids are not being metabolized at the cellular level. They're being metabolized instead of glucose, and that's what produces the acids and ketones, which is ketoacidosis. But that's not what makes them excessively thirsty. The thirst is secondary to the ketoacidosis, which is what the question's asking you. And D, hyperglycemia usually causes severe internal water loss. That's totally false. I just explained to you what actually causes the water loss like 3 times in a row. So it causes water loss here also due to glucose being excreted and not metabolized at the cellular level. So that extra fluid goes out, and that's where they get the thirst from. Hyperglycemia this is not the definition of hyperglycemia. Question 11. When dealing with hematologic disorders, the EMT must be familiar with the composition of blood. Which of the following is considered a hematologic disease? A, sickle cell disease, B, hemophilia, C, Lou Gehrig's disease, and D, both A and B. This one should be really easy. And of course, it's D. Hematology is the study and prevention of blood-related diseases such as sickle cell disease and hemophilia. So let's look back at the incorrect ones. When dealing with hematologic disorders, the EMT must be familiar with the composition of blood. Which of the following is considered a hematologic disease? A, sickle cell disease. We know that this is a hematologic disease because it affects the red blood cells. It causes them to be misshapen and they jam up in the tiny blood vessels, as we discussed earlier. Hemophilia, it's built right in the name. Hemophilia is a hematologic disorder, and it affects the blood's ability to clot. In other words, it either is very limited or ultimately cannot. C, Lou Gehrig's disease. This affects the nerve cells in the brain and spinal cord. That is definitely not a hematologic disease. And your pop quiz that I'm not going to give you the answer for, it's going to make you look it up, so I know you're going to love me for this, is to go back and tell me what type, or look up for yourself what type of disease Lou Gehrig's disease is. In other words, if it's not hematologic, what category of body system does it fall under? So it is blank disease. I'll give you a hint. The first letter starts with the first letter of the word is an N. Okay, and then D, both A and B, that's the correct answer because, of course, sickle cell disease and hemophilia are both hematologic diseases. 12. What are the 2 main components of blood? A, erythrocytes and hemoglobin. B, cells and plasma. C, leukocytes and white blood cells. And D, platelets and neutrophils. This is definitions. So if you don't know the answer to this one, we're gonna review it right now. But I'm gonna take this brief opportunity to say, know your definitions and what the definitions of terms are, and be very clear on them. The answer is B. Blood is made up of 2 main components, cells and plasma. The cells in the blood include red blood cells, erythrocytes, white blood cells, leukocytes, and platelets. These cells are suspended in a straw-colored fluid called plasma. So to review the incorrect answers, what are the 2 main components of blood? A, erythrocytes and hemoglobin. This is incorrect. Erythrocytes are a type of blood cell, and hemoglobin is actually the chemical contained inside blood cells themselves. So it's asking you what the main components of blood are, and that's B cells and plasma. And that's easy to visualize and you remember in your mind, because if you put a test tube of blood in a centrifuge and spin it, the cells will separate out from the plasma, so you wind up with a clump of cells that look red, but of course they're red blood cells, white blood cells, and leukocytes. And then the clear fluid is separated from it, and that's the plasma. So that's an easy way to remember what the composition of blood is. The 3 types of cells and the plasma. Okay, cells and plasma. C, leukocytes and white blood cells. Well, here's the definition thing I was talking about before and have mentioned several times. Leukocytes are white blood cells. So, again, know your definitions. That's a type of blood cell, and of course, that is in blood, but it's not one of the main components. The 2 main components are leukocytes, red blood cells, white blood cells, the blood cells, and plasma. D, platelets and neutrophils. Again, know your definitions. Platelets are a type of blood cell, and neutrophils are a type of white blood cell. So we're even moving into subdivisions of cells here. Okay, if you just remember that all blood cells, large and their subcomponents, are what float around in the plasma. That's the lubricant and fluid that they move through. Okay, then you'll never get this answer wrong. Those are the 2 main components of blood. 13. The assessment of a patient with hematologic disorder is the same as it is in all other patients that an EMT will encounter. In addition to obtaining a sample history, EMTs should ask which of the following questions. A, have you had a crisis before? B, when was the last time you had a crisis? C, how did your crisis resolve? Or D, all of the above? If you follow straight logic, this answer will be very simple also, but we are going to review it. And it is D. Sample. Sample, again, is the mnemonic used in the taking of history of all patients. In addition to asking the sample, EMTs should also ask about past crises. In other words, if somebody says to you when you're taking their sample history, and a conscious alert talking to you, and everything's good there, and you get ready to take their, when you talk to them about their history and they say, you say, do you have any existing medical conditions? Yes, I have hemophilia. Clue. When was the last time you had a crisis? And all of those other questions, which we're going to review right now. A, have you had a crisis before? That's the first thing to ask, because they may have been diagnosed and not known that they even had it yet. Like some minor incident, or it showed up in a blood test, etc. So depending on what type of hematologic disorder, in other words, somebody can have sickle cell and they had no idea. It just was discovered when they had a blood test for something else. So it's important to establish that, okay, you know you have it. Have you ever had a crisis before? Okay, so get that question out of the way first. Then ask them, okay, if you've had a crisis, when was the last time you had one? In other words, what was the most recent crisis you had? See, how did the crisis resolve? You need to know, did it resolve on its own? Did they have to have major medical intervention? You know, what exactly occurred there? Because that is a guide path for the doctor to consider when treating the patient at this point, whether it's for the hematologic disorder or anything else. It's a factor he has to take into mind, and what worked or what was used, what techniques were used previously. In other words, how did the patient find their crisis resolved? So again, D here is the correct answer, all of the above. 14. Which one of the following is not an appropriate treatment for EMTs to provide to a patient who has a hematologic disorder? A, analgesics for pain. B, support of symptoms. C, high flow oxygen therapy at 12 to 15 liters per minute. Or D, rapid transport. This one should be very straightforward also. And it's A. Although analgesics would benefit a patient suffering from a hematologic disorder, The administration of such medications is not in scope of practice for EMT. ALS providers would have to be present to provide that type of emergency care. So let's look at the other things. Analgesics for pain, that's correct answers. EMTs cannot prescribe analgesics. So that's kind of a trick question here. So it's making you remember, oh, yeah, this is my scope of practice. B, support of symptoms. Of course, that's an appropriate treatment. So manage their symptoms. If they're short of breath because perhaps they've got pneumothorax forming or whatever's going on. Support their symptoms and treat them. Moving on to letter C, high flow oxygen therapy at 12 to 15 liters per minute. That is definitely appropriate. And D, rapid transport, also appropriate because there's so much that can go wrong with a hematologic crisis. So make sure that you, again, review your definitions in this class. That is so important. And remember that earlier when I asked you, well, what type of disease is Lou Gehrig's disease? What I was trying to point out there is that some things are relatively commonly known, so and relatively common also, which is a shame. But Lou Gehrig's disease, if it affects the nerves, then of course that's the neurological system. So that is a neurological disease as opposed to a hematological disease. So I said I wasn't going to give you the answer, but there it is. Hopefully you looked it up. But that's one of the reasons that knowing the body systems so well and all of the key terms and definitions are so important. Because even if you don't know what a specific disease is, however, someone says, well, it affects my blood, then bang, it's a hematologic disease. You've already got very important information to move forward with. You know some things to anticipate, and you've got critically important information for the doctor. So take your time and review this chapter carefully, as I encourage you to do in every chapter. Know your definitions, not just for this chapter, but this is just a good point to remind you to know them for every chapter so that you're able to have solid brick foundation. Okay? Again, thank you for your time and attention, and we'll see you next class.